Good afternoon, good morning, and good evening, depending on where you are joining us from today. I'm Dr. Bethany Williams, and I'm the lead for training and education at the National Pathology Imaging Co-operative based in Leeds in the United Kingdom. And today is an incredibly exciting day for myself and for all the NPIC team as we launch our first in a series of NPIC educational webinars. So we'd like to start by just offering you all the warmest of Yorkshire welcomes. I had a quick look at the registration list today and I see we've got participants registered from 6 continents, lots of old friends and colleagues that we've met in the past, and also some new faces and some new names on the list. So it's wonderful to see you all. You are very welcome in. Over the last few years, we've made it our self-appointed mission to try and make digital pathology mainstream. So we've set out to answer some of the very fundamental questions that we might have as pathologists, as biomedical scientists, as laboratory managers or IT managers. We've tried to provide easily accessible, pragmatic publications covering the topics that really matter in clinical services. How do we deploy digital pathology safely and effectively? And we've also tried to guide other departments on their digital journeys and, of course, learn from their deployments and their experience. Now, in the past, we've been able to hold frequent digital pathology workshops at Leeds, where we've been able to invite you to come and see us, have a cup of tea, visit our digital laboratory, see some of our digital pathologists in action, and discuss some of the issues around deployment, training, and the evidence base for digital pathology. So sadly, the last few years have meant that's been impractical for us to do, but we are now trying to find new ways to share some of our experience and reach out to the digital pathology community. So in light of this, we have developed this webinar series for you. So I hope you'll be able to join us for some of our future events. We're planning on holding 8 seminars over the next 12 months. The format will be similar to today, 1-hour webinars with a couple of speakers and that ever important question and answer session where you get to grill our experts or maybe ask for a bit of advice on any of the particular problems or challenges that you're facing. We're going to be covering a wide range of topics ranging from quality assurance and remote working to laboratory deployment, AI development, the practicalities of digital reporting and digital pathology training and validation. I would suggest, these are all designed for a multi-professional audience. You are welcome to attend all of them, but if there's a particular session that you think it might be useful for particular colleagues to attend, say your biomedical scientists come to our laboratory deployment or quality assurance sessions, then you can, of course, dip in and out, and we're very happy for you to refer any of your colleagues that might be interested to come and join future sessions. And in the last 18 months, we've also opened our brand new National Digital Pathology Knowledge and Training Centre here in Leeds at St James's University Hospital. So we've got a fantastic purpose-designed space for offering hands-on workshops and training in the future as the situation permits. We've got dedicated spaces for lectures, meetings and hands-on demonstrations. And what's really exciting, we've got all sorts of wonderful digital pathology hardware and software from a range of vendors, allowing people to try out the new technology. And we really see this as an excellent opportunity to engage in multidisciplinary training and engagement, because what we all really want is to support the creation of a cohort of clinical workers who are confident and competent evaluators and users of digital pathology and artificial intelligence in pathology. And here is another resource that I would just like to point you towards if you haven't already downloaded a copy. This is the Leeds Guide to Digital Pathology, now available in 12 languages, plus a USA English version for those of you that can't stomach the UK English spellings. This is a sort of consolidation of some of the earliest lessons that we learnt in deploying digital at the Leeds laboratory, and I'm absolutely delighted that we now have the next chapter available. Leeds Guide to Digital Pathology Volume 2 is available for download, and we will share with you details of how to do that after this session. We're going to be updating some of the educational content here, including a more in-depth dive into ISO accreditation of digital pathology services and the practicalities of remote reporting. And we're also going to be exploring just some of the experiences and thoughts of some of our pathologists, biomedical scientists and surgeons who have all been getting to grips with digital pathology over the last few years. So that's two things to look at. Now, I'm mindful we have a busy agenda, so I'm going to move on to our guest speakers for today. We have Dr. Darren Traynor, who's the Programme Director at NPIC and the Chair of the Royal College of Pathologists Digital Pathology Committee. And we also have Dr. Daljit Bansal, who is Operations Director at NPIC. They're going to be telling you a little bit more about the programme and how NPIC has expanded from a local to a regional to a national digital pathology programme, and explaining some of the particular challenges and opportunities that they've encountered across the way. And I think Darren is also going to give you some of his top tips and experience from more than 10 years working in the digital pathology field. He's going to give you some of his top tips for deployment in the clinical setting. So lots of useful things there. So with no further ado, I will hand over to Darren and Dal. And if you have questions for either of our speakers today, please do start and put them into the chat during the session. And then when we get to the Q&A at the end, we will pick out as many of those as we can cover. So just pop those in the chat there. Thank you. And I will hand over to Darren Traynor.
Thank you, Bethany, for the introduction, and hello. I'm Darren Traynor, a pathologist at Leeds, and I'm the Director of the National Pathology Imaging Co-operative. I'm going to talk today about the work that we've done from the early steps of implementing digital pathology through to a national deployment. These are my financial disclosures. Bethany asked me to give an inspirational talk to kick off our webinar series today. And so, to get us started on a strong note, I've dug up my most inspirational quote about digital pathology. And that is that digital pathology is the future, and it always will be. And this was something that we'd noted over the past 20 years, that despite the promise of digital pathology, it seemed to be always in the future, never quite attainable. Digital pathology is a simple technology that allows us to take glass pathology slides and scan them on specialized motorized microscopes like the one that Chloe is loading on the left. Pathologists can then review the images on a computer workstation. And at its core, digital pathology or whole slide imaging is a really simple technology that takes glass slides and digitizes them with a motorized microscope. And whether it's the very earliest scanners that we bought in the early 2000s or the latest scanners that we've installed in our NPIC program, the result is a large image created from a microscope slide, which can be viewed on a computer screen. And it's such an exciting technology. Since the early days of having scanners at Leeds, we've found all sorts of useful and important applications of the scanners. For example, the Leeds Virtual Pathology website, which has an enormous collection of teaching and training material used by thousands of people around the world, or our educational power walls for collaboration, teaching and training. And despite the technology being so simple and so useful, yet we face this conundrum that it always seemed to be for the future. But at Leeds we have a history of adopting technology, but thinking about it carefully before doing so. And it was clear to us in the early days of digital pathology that it wasn't ready for prime-time clinical use. I spent a good deal of the first part of my career evaluating the acceptability of digital pathology and the efficiency of digital pathology. And a decade ago, it was pretty clear that pathologists would not use this technology, and nor was it suitable for clinical use. And when we thought about this problem, we came up with an analogy that explained perhaps why digital pathology wasn't gaining the traction that it perhaps deserved. And the analogy was that of this horseless carriage, a new invention that could do away with the need to travel on horse. And as you can see, the early versions of these horseless carriages had drawbacks and limitations. And as they evolved, they became more and more useful, more and more practical, to the point where they became something that everybody used and had around the world. And 10 years ago, when I gave talks about digital pathology, I would comment that we were probably here around this early stage of the automobile industry, with a lot of work to do still before widespread adoption. And the technology has undergone significant evolution over the past 20 years, and I feel privileged to have seen this evolution and played a small part in helping it along the way. The timeline on the left shows the uses we put digital pathology to at Leeds and our observations as the technology improved. And we'll highlight a few key points in this timeline. Around 2015, we established that the scanner image quality and the quality of displays that became available at that time were good enough to make a diagnosis in many cases. And this was substantiated by evidence from around the world that a glass and digital side could be non-inferior under the right circumstances. And that gave us the confidence at that point, marked with the sunshine icon, to go ahead with a pilot of digital pathology in our hospital, moving from our research and academic interest across to clinical use with our breast pathologists at Leeds. And the evolution and improvements have continued coming. For us, our 100% digital scanning milestone was reached in 2018, but we had a significant improvement to our digital pathology in 2020 when we implemented new scanners and a new image management system. And even this year, we've found incremental but significant improvements to our systems at Leeds. And I've highlighted on the middle two images that just show an epiphany or a eureka moment for us at Leeds. The image on the top is an image from an AT2 scanner. We've been using these scanners for nearly a decade at Leeds, and we're very happy with them and had successfully adopted primary diagnosis in several areas using them. But we upgraded those scanners to a GT450 as part of our NPIC program, and the image on the bottom is a GT450 image. And although they're both fit for purpose in terms of making a diagnosis, the color management and the fidelity to the microscope of the image on the bottom is substantially better, which means that working digitally is just easier. It's easier to be smooth and accurate. It's easy to be quick. And this small incremental improvement was actually a major improvement for us as a digital pathology program. And a second small and almost trivial example is our ability this year to implement a new staining system that uses the same racks as our GT450 scanners. And although as pathologists we're often not concerned with these small workflow issues in the laboratory, this allowed us to go straight from the staining instruments onto the scanners, taking away, I would say, the last significant roadblock to digitization in the lab. Nobody at Leeds can complain that slides are delayed by whole slide imaging now, because we have a straight through from stainer to scanner workflow, and we have sufficient scanners which are fast enough to scan everything within a very short period of time. And so the evolution of this technology has allowed us to be more and more confident in our use of digital pathology in Leeds and start thinking across the region and across the country. But while the technology has been developing, the need for the technology has also grown. This is a slide that I've used many times to illustrate the various reasons why you'd want to adopt digital pathology, perhaps with a UK focus, but global applications. On the left, we have some demographic and workload figures showing the shortage of pathologists and increasing demand for their use. Bethany has done a great deal of work summarizing the benefits of digital pathology and the potential benefits of it along the lines of 4 major themes: efficiency, safety, quality improvement, and as a platform for further techniques. But I think you just need to show somebody my desk on a Monday morning 10 years ago with piles of patient slides, bits of paper, disorganized, or the workflow that we use in laboratories to maintain patient samples to say maybe digital is a better solution. So we've reached a tipping point with digital pathology where we have fast scanners, good image viewers, image quality good enough for primary diagnoses. We've now got the knowledge and processes to run them safely in the laboratory and validation processes such as the Royal College guidelines in the UK to ensure that it can work clinically safely. And there's an increasing need, as evidenced by the pandemic, for remote working and flexibility of workforces. So we're reaching a point where digital pathology's technology has improved to the point where it's very usable, and the clinical need and health service need is significant. And the evolution of our use of digital pathology at Leeds has echoed that improvement in the technology from our first steps nearly 20 years ago through to cautious clinical use in 2016 onwards, and now looking at a regional and very ambitious national rollout. And this is a stepwise natural progression as the technology has improved. When I use the automobile analogy that I gave earlier, people were often fond of pointing at the end of my talks that there was a new technology that had advanced automobile physical technology even further by enhancing it with information technology and artificial intelligence. And I think that analogy is a very nice counterpart to the digital pathology situation that we see ourselves in today. And while digital pathology scanners and technology have been evolving, there's been a revolution in the world of information technology as well, with the advent of powerful, capable artificial intelligence that's beginning to show benefits in our own area of pathology. And this has taken the notice of governments and healthcare systems, including in the UK, leading to a significant interest in the use of digital pathology and artificial intelligence to improve healthcare. And it's against this backdrop of enormous increase in technological power and a significant clinical need for the benefits of digital pathology that we set our NPIC programme. We have an evidence-based, pathologist-led approach to our deployments of digital pathology, and a recognition that artificial intelligence is an opportunity and a challenge for our profession. So we established the National Pathology Imaging Co-operative, and it has three simple aims: to drive the clinical use of digital pathology, to participate in artificial intelligence development and evaluation over the whole life cycle from early data gathering through to implementation and quality assurance, and also to provide a platform for further research and innovation in pathology. And that brings us to the beginning of the first part of today's webinar. Next up, Dr. Dal Bansal, our Operations Director, will introduce NPIC and give an overview of the programme. And I will follow up with a top tips for digital pathology deployment based on our 18 years of experience at Leeds. Please stay with us.
Hello, and thank you for joining me to hear more about the National Pathology Imaging Co-operative NPIC. NPIC is one of the largest digital pathology and artificial intelligence programs in the world. As the Operations Director, I am responsible for the delivery of the program, and I lead on the research strategy. NPIC has been at the forefront of leading innovation in practice for digital pathology and AI research for a number of years, almost 2 decades in fact, which could be defined as nearly as old or young as the technology itself. Hosted by Leeds Teaching Hospitals, NHS Trust and the University of Leeds, the programme is home to world-renowned expertise in clinical deployment of digital pathology, with St James's Hospital site becoming the first UK hospital laboratory to be fully digital since the inception of NPIC in 2019. In the last 3 years, which we are all aware has been one of the most challenging times, as we look to recover from a global pandemic, NPIC has continued to support NHS hospitals and medical centres around the world to invest in the technology. At world-leading scale, NPIC has invested to deploy an end-to-end digital pathology solution in over 30 hospital laboratories in England. You'll hear more about this shortly. To note, NPIC has significantly invested to support what has become the largest digital transformation programme in the NHS, generating 3 to 4 petabytes of image data per year in a single national digital pathology system. The primary aims of NPIC are to drive clinical use of digital pathology and become the go-to place for AI development and use over the entire AI lifecycle. It is well recognised that building AI systems will fail unless you have high-quality data. I think we are all familiar with the analogy garbage in and garbage out. The idea of NPIC is to set the groundwork and establish the building blocks to create a platform for both clinical deployment and AI research, working in collaboration with our key stakeholders. Our approach has been to work cooperatively. As the C in our name suggests, we have been fortunate to be working with over 30 partners across the NHS, academia, industry, and most valuably, had involvement from patients and members of the public. Here is an overview of our partners within the consortium, which ranges from not only the NHS sites that are deploying the digital pathology solution, but also includes the established university network focusing on AI research and data ethics. The industry partners represent 90% of key contributors in digital pathology and includes SMEs that are developing AI products right through to major scanner vendors like and Roche, and also our PACS provider, Sectra. We are also proud that our collaborative ethos encourages interoperable and partnership working, providing access to specialists in their field and access to multiple hospital sites. I take the opportunity now to provide an overview of how the partners are embedded across the NPIC work packages. To fulfill the aims of NPIC and in collaboration with our partners, we have a number of work packages. This includes a quality assurance work package led by Professor David Breton in collaboration with FFEI and Through Tomorrow. There's also a programme of clinical deployment led by Bash Hussain, which started with the installation of the Leica digital pathology scanner at Leeds and now has expanded at a significant scale. Alongside this, we have a precision medicine research work package led by the N6 University Network and Roche. NPIC does provide a complete solution with the Sectra PAC system and intuitive synaptic reporting tool for providing structured pathologist reports, and alongside working with clinicists and X-Labs, supports laboratory management systems and platforms for image exchange. We also have significant investment in our data ethics work package led by the University of Oxford and our patient and public advisory group led by Mr. Graham Presswich are key to this work. There are a number of AI exemplar projects led by different partners Leica, Roche and Heterogeneous. NPIC is leading one of the largest regional programs of digital pathology deployment and supporting the full digitalisation of 15 NHS trusts across 3 NHS improvement pathology networks in the north of England. A population of over 6 million are set to benefit from the clinical use of digital pathology, and collectively the programme will generate over 2 million images and 3 to 4 petabytes of data per year. To support and standardise the acquisition of high-quality data, our solution was to build a central technology known as a vendor-neutral archive. The VNA is based on the International DICOM standard for making medical imaging information interoperable. Our VNA system allows users to store any DICOM-compatible image acquired from any scanner using any software such as PACS. The solution is scalable across multiple sites and specialist tumour networks, allowing any developer the option to plug in their AI or image viewing tool on top of the image stack. NPIC is working with a number of scanner vendors and PACS providers to achieve full DICOM compatibility to provide a secure national solution for image and data storage. The home of NPIC is the National Digital Pathology Knowledge and Training Centre in the City of Leeds. The centre will be running a number of workshops and training events for pathologists and biomedical scientists. We look forward to welcoming you soon to one of Bethany's world-renowned workshops. The centre provides dedicated incubator space for industry ranging from startups to SMEs, where our dedicated research team can help facilitate unmet needs workshops and collaborative research opportunity working across our network of NHS sites. Also within the centre is a dedicated multi-scanner facility, currently housing 7 to 8 scanners from multiple vendors. The facility is the only one of its kind, representing 99% of the scanner vendor market, allowing AI companies to replicate datasets across multiple platforms to help facilitate AI development and evaluation. I'm responsible to deliver NPIC's research strategy, and my team of research operational and technical project managers can help facilitate research partnerships across the entire AI lifecycle and support opportunities within all the work packages. In working closely with our patient and public advisory group, clinicians, industry and academics, the team can provide access to subject matter experts and end users across the NPIC network, supporting with funding applications and gaining access to images through our central image repository and scanner facility, supporting real-world evaluation of AI, including clinical trials, regulations and adoption in the NHS, therefore placing NPIC at the forefront of AI and imaging and other omics. I'm excited to share our flagship project, led by Dr. Charlotte Jennings, is recently published in Nature Medicine. In collaboration with Genomics England and NPIC, the project referred to as GPIC aims to retrospectively scan all of the pathology slides associated with participants from the 100,000 Genomes project. A total of 300 slides will be provided into the Genomics England trusted research environment, creating one of the largest unique resources for pathology genomics correlation in the world. Building on the scanning of the 100,000 Genomes project, NPIC has established links with 2 of the Genomics England Clinical Interpretation Partnership subgroups, GSIPs, in paediatrics and sarcoma. NPIC will support the full digitalisation of these 2 national networks. The National Bone and Soft Tissue Network is led by Professor Adrian Flanagan. As part of NPIC's commitment to scale up digital pathology nationally, we are leading on the digitalisation of the Royal National Orthopaedic Hospital and accompanying hospitals within the network where cases are reviewed. The digital solution will provide a significant benefit and address the serious growing shortage of specialist pathologists, where in this case there are only 5 pathologists in the country that can provide a diagnosis for bone and soft tissue tumours. The National Paediatric Pathology Network, led by Professor Neil Sabir, will see NPIC lead on the deployment of digital pathology at Great Ormond Street Hospital for Children, and also provide a number of scanners at hospital sites within the paediatric network, and ultimately providing a significant opportunity for second opinions and national multidisciplinary team meetings for the diagnosis of children's cancers. In summary, our national solution, the VNA, supports both clinical and research requirements by leveraging the benefit of working across multiple hospital sites who will contribute images to a single large-scale repository, offering robust data for AI development and real-world evaluation across multiple sites, and also supporting international clinical trials. Nationally, NPIC are leading the way in pathology and genomics correlation, and we are interested in establishing further links. Starting with our 2 national networks in paediatrics and sarcoma, the first of the 2 GSIP sites to be prospectively scanning, we will continue to lead innovation and practice, and we look forward to working with you to further scale our solution in both research and the deployment of digital pathology and AI. Thank you for listening. I'll hand you back over to Darren to wrap up with some helpful hints and tips for digital pathology as you begin or continue with your journey.
Hello, and in the final part of our webinar today, I aim to give you some top tips and lessons learned from our 18 years of digital pathology deployment at Leeds. As I said, I've been doing digital pathology since pretty much the beginning of my career in pathology, And while the scanner models have significantly improved since then, I'm not sure I have. A quick update on where we are so far with our NPIC deployment, led by Bash Hussain, our deployment director, and Ian Mason, our program manager. We've established our central vendor-neutral archive in the program and procured 10 petabytes of storage to serve our hospitals. We've gone live at Leeds with our PAC system, supporting 6 scanners with over 1 million images or a petabyte of image data to date. And we expect 10 or more sites to go live in NPIC over the next 12 months. This slide gives you an idea of the scale of the NPIC program. Bash and Ian's teams have been going all around the country, engaging with potential NPIC sites. And we're pleased to say that we've now got scanners procured and on site as the beginnings of our soft tissue and bone cancer network and our pediatric cancer networks, with more to follow. So, as promised, my top tips for digital pathology, or perhaps my 18 years of making mistakes so you don't have to. I could summarize my top tips in one slide, which is that we've always been an evidence-based, scientifically led digital pathology program, and we write everything down that we do. So Bethany has created this list of all of the published work that we've done, all of the evidence, all of the guidelines. And I particularly highlight the Leeds Guide to Digital Pathology, a freely available download, which has almost all of what you need to get started as a digital pathology program. So, based on our multiple generations of digital pathology scanning over 18 years, this is our general advice about going digital. I did training as a computer programmer in the early stages of my career, and in software engineering we have a phrase that to err is human and to really foul things up requires a computer. And that is one of the key principles of my approach to digital pathology. So, digital pathology is a very big IT project, a new technology, a big transformation of your lab, and a substantial alteration to how we practice pathology currently. And as Bethany says, what could possibly go wrong? So when we're asked how did we go digital at Leeds, we tell people that we have a perfect laboratory and perfect staff. We have a perfect digital pathology system, a perfect lab information system. We know everything there is to know about digital pathology. We planned the project perfectly. We ran it perfectly. And everything worked perfectly just first time. And if you just do what we did, you'll be fine. And perhaps too many talks about digital pathology focus on how successful things are and how great the technology is. And we pride ourselves at Leeds on taking a more evidence-based, realistic approach to the technology. We've run a great deal of in-person workshops at our Leeds laboratory, and Bethany devised this participant evaluation system. When you arrive in our laboratory in the morning, we give you a star and ask you to rate yourself on this chart. On the horizontal axis, how much do you know about digital pathology? And on the vertical axis, how positive are you about the digital pathology technology? And the people who come to our workshops are often tentatively knowledgeable about digital pathology and mostly generally positive with a few skeptics. And by the end of the day, this is where they move their stars to on our evaluation chart. Generally, their knowledge of digital pathology has increased, but their positivity about it has decreased or been tempered. And that might look like a strange thing to be happy about, but for us that's evidence that they understand the technology and the challenges in implementing digital pathology. And I think we've done our job when we see this result. So, apart from that general health warning about going digital, these are some specific top tips that you can use to go digital in your laboratory. Number 1, think big, but start small. The flowchart on the left shows the stepwise approach we took to digital pathology at Leeds, cautiously implementing in breast pathology and neuropathology before rolling out in a more widespread laboratory use. And the graph on the right shows the percentage of surgical pathology slides we scanned in the 2018 calendar year, and it shows the stepwise approach to rollout. This allowed the laboratory to plan ahead, to compensate for changes to workflow, and for staff to become familiar with the processes. So top tip 1 is to take it one small step at a time. Put some scanners in your laboratory, scan some slides, get some of your pathologists to make some diagnoses, and you're doing well. You should be realistic about your goals. We advise a large number of laboratories around the world about going digital. And when we hear people plan to go from 0% scanning to 100% scanning, having done no pre-work and preparation in 1 year, we're skeptical. And we're particularly skeptical when people plan to, in parallel, develop their own artificial intelligence 6 months into the program. And the analogy we would like to give you is that when you're learning to drive a car, the first car you buy is not a Ferrari. So if you're thinking of going digital, take it a step at a time and don't overreach in the first 1 or 2 years of your program. Tip 2, do your homework. That is, review the knowledge and evidence that's out there, publications, visit as many digital labs as you can, attend webinars like this, and in-person workshops if possible. Our deployment was based on a significant amount of pre-work examining laboratory workflow, laboratory metrics, such as the value stream map comparison on the left, comparing our current analog state and our future desired digital state. The options appraisal in the middle, which was asking the simple question of where should we put our scanners in a laboratory. And you can take some action. You can do significant laboratory preparation, and you can try scanners out in terms of their throughput and their image quality, and try out displays. All of this is summarized in the Leeds Guide to Digital Pathology shown on the right. Tip 3, choose your partners carefully. Of course, you want the best scanner, but you want the best scanner for your needs. You want the best image management system and viewer. You want the displays that work for you, the right type of storage at the right price, and you want increasingly standards compliance such as DICOM. We've chosen our partners very carefully at Leeds over the years, and they're shown in the logos in the middle. And the general points we would make about our partner is they truly are long-term partners that you've got to work with and work closely with. And having a synergy, a similarity of outlook is really important. You need a partner that's collaborative, you have shared goals and are willing to face joint challenges together. You want a partner who's willing to be flexible and compromise with you. And for us, a partner that doesn't exhibit the St. Elsewhere approach of everything being perfect and everything working first time. And I think I've chosen an analogy here that it's a relationship, a long-term relationship that's quite important. So be careful who you choose as your partners. If I was to give one tip to overrule all tips, it might be number 4. Get your team together and get the right team together. You will need a substantial project team with external help. Pathologists are not familiar with project management, and you need a professional project manager, at least one, to manage a deployment in a small lab. On NPIC, we have a team of over 8 project managers at the moment. You need a pathologist to lead the program clinically, but also pathologists to be engaged with the program. Biomedical scientists and technicians who are going to undertake that substantial change in the laboratory, pathology managers, and of course the input of your IT department from the early stages. You'll need to learn a new word about project management called stakeholders. Stakeholders are people who care about the outcome of your project or people who have an influence on the outcome of your project. And that will include the executives in your pathology lab or in your hospital. It will include the clinicians that you work with, and it may include patients and the public. And you are going to get to know your team and yourself very well through your digital pathology deployment, so choose them carefully. And of course, you must know the most important stakeholders in your project, your users, your pathology colleagues who are going to be using these scanners and these images to do their jobs. And Bethany Williams has designed this characterization of your users, which we found to be remarkably consistent across digital pathology deployments worldwide. First of all, the enthusiasts who come to your attention immediately. They'll approach you because they're enthusiastic about digital technologies and they want to try it out. They're very important because you can engage with them to establish your processes, try things out before you go fully digital. At the other end of the spectrum, you have your skeptics, people who are unsure whether they want to be working digital or in fact against working digitally. And these are also a very important group that you have to engage. They like a chance to prove you wrong, so they're very good at finding the faults in your plan, the faults in your system, which you can use to improve things. So we see the skeptics as a very good test for digital pathology. And Bethany has observed that perhaps the hardest group to engage are the uncertains, the quiet group in the middle who are neither particularly pro-digital pathology or particularly against it. And they often want the safety of knowing that things are going to be okay if they go digital, and they will explore it once you've established that everything is as it will be. And my final tip is to recognize that digital pathology is a challenge and to accept it. If you choose not to accept the challenge, you could simply wait 5 years for everything to get better, more mature and easier, as you see the technology is getting better all the time. However, I think you might regret that if you made that decision. If you look at this fictional star chart that I'm showing here, our experience is that after digital pathology is deployed, users become more and more engaged with it and find more and more important uses of the technology in their own lives, in their own careers, and in their own laboratories. And I think it's safe to say that once you've gone digital, you will never go back. Now, as it's our first ever NPIC webinar, I thought those of you who stayed on long enough to listen to the end should have one final bonus tip. So I've lined up the most important slide of the day for last. And that tip is that you can join NPIC. We've spent 18 years planning this program and have got significant funding to build a massive centralized infrastructure, providing a single digital pathology system, a single teaching and training system, and allowing you access to a large national network. NPIC provides shared processes and documents, including contracts, procurement advice, ethics and legal agreements. And because of our world-leading scale, the costs are lower. Dal and her team can facilitate research collaborations in pathology and artificial intelligence, and we have a dedicated research environment with significant amounts of storage and compute. And we offer the possibility in future of centralized AI rollout, so you don't have to worry about the details of that. If you're interested in this, get in touch with the NPIC team and we'll let you know what we're going to do in future. And I'll finish with our acknowledgement slide, acknowledging our hospital sites, our academic partners and our industry partners, paying thanks to the NPIC team, including the team who've put so much work into putting these webinars together today. Thank you. And we'll now take questions.